So first I'm going to review the current practice just very briefly and then get right into the approved systemic therapies because we've had quite a few approvals in the last few years. So I'm going to jump right into that after a few slides. So we're all very familiar with the statistic of estimated new cases of over 280,000 and 40,000 estimated deaths. So our current practice for stage 1, surgical resection, and then adjuvant therapy, so plus or minus chemotherapy, hormonal therapy, and HER2 targeted therapy, depending on the subtypes. And then stage 2 and 3, we tend to do a lot more neoadjuvant therapy for tumor downstaging. That also helps us to decide what sort of adjuvant therapies we would offer. So for example, in triple negative breast cancer with residual disease, we would discuss Xeloda or capecitabine for that patient. Or in a HER2 overexpressed tumor, we would discuss with them continuing their HER2 targeted therapy, which may be Herceptin plus or minus pertuzumab or Kadcyla. And then for our metastatic patients, hormonal therapies plus or minus a CDK4/6 inhibitor, HER2 targeted therapy and HER2 positive, and then chemotherapy and now immunotherapy for triple negative. So we're going to go right into what the newer therapies are, and we're going to go a little bit in depth in the studies that led to their approval. So I'll first start with the neoadjuvant space. So the first one is pembrolizumab for early triple-negative breast cancer. This is in combination with chemotherapy. And the pembrolizumab is also continued in the adjuvant setting. And the goal of this study was to determine if adding pembrolizumab to chemotherapy would increase the percentage of pathCR in early triple-negative breast cancer. So this is our Keynote 522 study. It was a phase 3, randomly assigned 2-to-1 ratio in untreated stage 2 and stage 3 triple-negative breast cancer. You'll see the two groups here were very well balanced with age. They looked at PD-L1 status, plus or positive or negative, stage 2 and 3 disease. And the patients received 4 cycles of pembrolizumab, as well as paclitaxel, carboplatin, and AC, majoromycin backbone, compared to patients who got chemotherapy without the pembrolizumab. And the pembrolizumab was continued for 9 cycles in the adjuvant setting. So again, the pathCR was one of the primary endpoints, along with